Welcome, and thank you for joining us. Today's webinar is a continuation of our ongoing series to provide information about COVID-19 vaccines. I want to thank the Jewish Federation of Cleveland for providing this opportunity for our community. We have more than 200 individuals on this afternoon session. My name is Andrea Kanter Grodin. I'm a Federation volunteer and the Executive Director of Operations at Cleveland Clinic. It's a pleasure to be part of today's webinar. I'd like to recognize Jewish Federation of Cleveland Board Chair David Heller and Federation President Erica Rudin-Luria for their inspired leadership. You have both navigated this past year with tremendous skill. One of the core strengths of our Cleveland Jewish community is how we care for each other. In the past year, your Jewish community, Federation, agencies, schools, and other partners have demonstrated strength, determination, and a resolve to work together to face the coronavirus pandemic and its impact on our community. And thanks to the generous support of donors to the Federation's annual campaign for Jewish needs, we've been able to respond to many of the immediate needs of our Cleveland community. We are providing food to the hungry, care for the elderly, and support to those who have financial challenges. If you are struggling or you know someone who is, please contact the Access Jewish Cleveland at 216-292-INFO or online at accessjewishcleveland.org. All inquiries are completely confidential. Every member of our community is important, and we want you to know we are here for you. We can't do it alone, though, and we need your help. We're seeking volunteers of all ages through Federation's Jewish Volunteer Network to assist members of our Cleveland Jewish community. Please contact Susan Hyman to participate in these opportunities. Since the pandemic arrived in Northeast Ohio, the Jewish Federation of Cleveland has hosted numerous webinars featuring recognized thought leaders on the front lines of COVID-19. We want to ensure that you get the most up-to-date information available so that you can keep yourself, your family, the community safe, healthy, and informed. Today, we are thrilled to continue the discussion with two experts in the field, Dr. Robert Wyllie and Dr. Stephen Gordin. Dr. Robert Wyllie has been Chief of Medical Operations at Cleveland Clinic since 2011. In this position, he's responsible for the activities of a variety of units, including business intelligence, pharmacy, hospital admissions, transfers and bed management, and critical care transport. He also serves as the medical director for government relations for the Cleveland Clinic. Prior to his current role, Dr. Wyllie was chief of Cleveland Clinic Children's Hospital, chairman of the Pediatric Institute, and the first holder of the Calabrese Endowed Chair in Pediatrics. Dr. Wyllie is also a world-renowned pediatric gastroenterologist with subspecialty interest in inflammatory bowel disease and complex endoscopic procedures. Dr. Wyllie graduated with honors from Indiana University School of Medicine, where he also completed a residency in pediatrics and a fellowship in pediatric gastroenterology and nutrition. Dr. Wyllie brings a unique perspective to this conversation, however. He has not only led Cleveland Clinic's response to the pandemic, he heads up Zone 1 for the state of Ohio. This is comprised of the northern portion of the state, including Cleveland and 21 other counties. Over the past year, he has helped to coordinate care, PPE, and equipment needs among dozens of hospitals in our zone. He's been an advisor to state leadership, overseeing COVID-19 testing in the region, and he now leads Cleveland Clinic's Vaccine Steering Committee. Dr. Stephen Gordin is chairman of the Department of Infectious Disease at Cleveland Clinic, and he's a staff member also in the Transportation Center. He is certified in internal medicine as well as in infectious disease by the American College of Physicians. His specialty interests include healthcare epidemiology, infective endocarditis, and cardiac device infections. Dr. Gordin earned his medical degree from Cornell University Medical College. He completed an internship and residency in internal medicine at the University of Chicago Hospitals and Clinics, as well as a residency with the U.S. Public Health Service. He was a fellow with the Centers for Disease Control Hospital Infections Program, and as well as being a fellow at Emory University Hospital in Atlanta. As Cleveland Clinic's top infectious disease expert, Dr. Gordin has truly been on the front lines of this pandemic. He's spoken to local, national, and international audiences about COVID-19. Dr. Gordin has been at the forefront of research, and treatments for COVID-19, and he's now one of the lead clinical voices on Cleveland Clinic's Vaccine Steering Committee. We are so grateful to have all of you join us today to share your insights. Dr. Wyllie and Grodin will begin by sharing some data, vaccine information, vaccine distribution plans, and answer many of the questions that were previously submitted when you registered for this event. You may submit additional questions through the Q&A function on the webinar, and time permitting, we will address them. So welcome, Dr. Wyllie and Dr. Grodin. Dr. Wyllie, I understand you're going to start first.
Thank you, Andrea. It's a pleasure to be here, and hopefully we'll be able to give you a little information, as well as answer some of your questions related to where we are in the pandemic and about vaccines. So with the first slide, please. Next slide. So just to give a little background to see where we've come over the last year, the first case in the United States of COVID-19 was on January 19th, 2020. I know it seems a lot longer than that to most of us. The first case in Ohio was actually under a year. It was March 9th. But look what happened. On March 9th, the governor declared a state of emergency. 3 days later, the schools were closed in Ohio. 3 days after that, bars and restaurants were closed. And within 2 weeks of the first case, on March the 23rd, Director Acton, the head of the Ohio Department of Health, issued a stay-at-home order. The first Cleveland Clinic case occurred a few days after the first case in Ohio, and it came into the hospital on March 13th, 2020. Just to give you a little background about where we are now, this morning, the US had 27.8 million cases with 488,000 fatalities. We're averaging 81,000 cases a day. That's a drop of 43%, but still well above we were in the first two peaks, and we'll show you that data. We also have about 2,200 fatalities a day in the United States. 65,000 people are hospitalized, but that's a drop of over 50% from the maximum number of hospitalized on January 6th, which was above 132,000. In Ohio this morning, we had 943,000 patients diagnosed, 16,500 fatalities, and we're averaging about 2,600 cases a day. There's been a substantial drop there to about 40%, but we're still at 2,600 cases a day, which is ahead of where we were in the first two peaks. We're currently coming off our third peak, and there are about 44 deaths a day. Good news is the testing positivity rate has dropped from the 20 to 30% range down to 4.2 in the last 24-hour period. The number of hospitalized in Ohio is about 1,566. That's a drop from 5,300 on December 15th. So a dramatic drop, but still pretty high. In terms of the vaccine, we vaccinated 48,270 at the Cleveland Clinic and 1.3 million in the state of Ohio. The vaccinated rate in the state is about 11.3% of the population, and about 4.2% have received 2 doses of either the Pfizer or Moderna. Around the United States, so about 1.3 million people have been vaccinated, and nearly 500,000 have received the vaccine. Moving on to the next slide, you can kind of see where Ohio's been compared to the US in terms of the number of cases since our first case that we talked about on March the 9th. And you can see really the cases in Ohio have mirrored the cases in the outbreak nationally. Next slide. This shows us our 2 peaks in Ohio. You can see there was a peak on April 19th, and about 90 days later on July the 28th, there was a second peak. And then, as I said, there were about 2,000 cases noted yesterday. But if you look at the cases yesterday, it's still well above either of the earlier 2 peaks, even though we're on the downturn of the infection. Next slide will tell you about the hospitalizations and the number of people in intensive care, as well as the number of people on ventilators. So the number of people on ventilators is in the green, and the number of people in the ICUs is in the red. And you can see the total number is 1,566. Again, a significantly downward slope from that maximum of 5,300 in mid-December, but it's still above the previous 2 peaks in April and in July. So keep that in mind that we're getting better, but we're clearly at a pretty high level. Next slide. So where does Ohio sit in terms of the vaccine and what we're trying to do and where we're trying to go? Well, the state determines the amount of vaccine that's allocated to each of their jurisdictions. That means hospitals, local health departments, CVS, Walgreens, Rite Aid, and Kroger's. So everybody who gets the vaccine is notified once a week. Typically that's on Thursday, but the state doesn't know until Tuesday at the end of business day how much the state is going to get. So for the national distribution, the state of Ohio gets about 3% of the vaccine. The Cleveland Clinic gets about 3% of that. The middle slide is a picture of our freezer farm, and we have cold freezers which can store either the Pfizer or Moderna. We can store hundreds of thousands of doses. Unfortunately, we typically get about 3,000 to 3,500 doses a week. We can give up to 5,000 a day, but our distribution is limited to that. On the far right, in terms of the map, you can see the 6 sites that we've chosen in terms of giving vaccine. So in the middle is the main campus of the Cleveland Clinic. On the east side is Hillcrest. On the west side is Fairview. You should drop down. We go to Medina Hospital. And then far down on the right is Union Hospital in New Philadelphia, Dover. And in between those two, near Akron, is Bath. The reason we're in Bath is because we made an agreement with the SUMA Health System, as well as the local county Department of Health in Summit County, that they would cover Akron City and we would move out to the suburbs, and that way we could distribute vaccine to more people. Next slide. So in the US, total of 55 million doses given, about 39.6 million people have been vaccinated. That's 11.5% of the population. We're giving about 1.7 million doses per day. How long will it get to get that herd immunity that we all hear Dr. Fauci talking about 75% to 85%? To get to 75, it's going to take 8 months at the present distribution rate. And that's why there's a lot of pressure on the new Biden administration to try to increase production and to try to increase the number of doses there are for distribution. In Ohio, a total of 1.8 million doses we have on hand. 1.3 million have been distributed. As I said, it's about 11.3% of the state, and approaching 500,000 have been fully vaccinated. We're given about 200 to 250,000 doses per week, which is our 3% of the national distribution that comes to Ohio. At that rate in Ohio, to get to that 75% herd immunity that everybody's talking about, it would actually take us 9 months to get there. So again, a big push at trying to get more doses out early. As you're aware, in the last couple of weeks, the Moderna and Pfizer have each been contracted to give us another 100 million doses. In total, there'll be 300 million of Moderna, 300 million of Pfizer, and they should be in our hands or in the government's hands by sometime in July, with hopefully distribution within the next 6 to 8 weeks after that. Next slide. So one of the things that Ohio has done in terms of its distribution is the governor has said, gee, every week for the last several, we're going to include a new age group. So we started at 80, going down to 75, 70, and now we're at 65. In addition, this week on the 15th, we started with some medical conditions, most of which are inherited conditions. They range from Down syndrome to CF to sickle cell anemia. And then you've got a couple of things where people have to be hospitalized. Like on the third column over there, the people with severe asthma who've been hospitalized in the last year, meaning they have pretty poorly controlled asthma, they will be eligible too. Now, how many people are there in this box? So in this box, there are about 200,000, but there are about 2.5 million Ohioans less than 65 years of age. And then if we count people in extended care living facilities who've also been on the list in terms of phase 1A and 1B, we're approaching 3 million people. And so far, we have 1.3 million vaccine distributed. So even though we have a whole bunch of people eligible, we don't have vaccine to give to all these people. So that leads to the frustration about people trying to get on lists and trying to call and do whatever they can in order to get a vaccine if they're anxious about getting COVID-19. Next slide. So what we've done in the Cleveland Clinic is we've reached out to the patients. So we started with our oldest, most vulnerable patients, and now we're getting down to that 65 range where we've offered everybody virtually above the age of 70. We've either called them, if they have a phone we can text, we texted them. If they're signed up for MyChart, we give them a ticket in MyChart as well as texted them to let them know that they could sign up and self-schedule for a vaccination. If we're calling them and they're not on MyChart, we'll schedule an appointment then. We also launched a public sign-up sheet, and that was last Monday. And the reason we did that was with the guidance of the state, who wanted us to participate in giving it to non-patients as well as patients. So we started a sign-up sheet. We're looking at that. We're marching down those same ages, and we'll offer those people vaccinations as well. And we'll continue patient invitations in decreasing order of age, and we'll incorporate the list of those medical conditions which also require vaccination, and those people need vaccinations. Next slide. So with that, I'm going to turn it over to Steve, and happy to answer questions. Thank you.
Thank you, Dr. Wyllie. And thanks, Andrea, and thanks to the Federation for the good work that you're doing. So I'm going to kind of hopefully pivot a little bit and talk about some other clinical aspects and a little bit of the epidemiology. Aaron, if I can have the next slide. So I like these two graphs. I think is trying to put it into perspective, this pandemic that we're going in. Of course, everyone reverts back to the 1918 influenza pandemic. And, you know, from this interesting book, which is a bestseller, a very good read, I think, by a physician. But if you look at the graph on the left, in terms of transmissibility, and then also in terms of mortality, you can see that this current pandemic that we're enduring really is the closest that we've seen since the 1918 pandemic. And for those of us that are old enough, you can see there is the 1968 influenza pandemic, the 1957 as well, the 2007 H1N1. But this really is a serious pandemic. And it's interesting as I see Dr. Wyllie show these numbers, you know, we've become immune to them in a certain point in terms of how much mortality and morbidity that we've endured, not just in the homeland, but throughout the world. The second slide figure I think is also important because unlike, or the difference between this and the 1918 is whom has been affected seriously. So in the 1918 pandemic, and you can see that in the kind of the dotted line, there were two big populations that actually were hit hard, not just the very young and the very old, but also young people. And if you remember in the third wave there, if you read the history, a lot of the soldiers and young people, this was obviously during World War I, really got hit hard. And if you look at our current pandemic that we're enduring, we describe it as in the blue line, more of an L-shaped epidemic curve, meaning that most of the mortality is being endured by the elderly or people that are greater than 65. And as we all know, if you look at even our long-term care facilities, although they've only accounted for about 5% of the total cases in the homeland, it's about 40% of the mortality. Now, this is not to say that kids don't get sick, and many of you have heard about other syndromes that can be severe in children, but we're in some ways very fortunate that we're not seeing a situation of children dying in large groups in terms of this nature. That would have a completely different effect, I think, on our population. The other thing is this informs us why the vaccines were initially have been developed for adults and not children. Although that is moving forward, but the initial push was obviously to protect those people that were dying from our SARS-CoV-2, and therefore it was the adult vaccination that got the fast track. Next slide, please, Aaron. I think the other thing is, as I look back on this and you can say, you know, why has this been so difficult to contain, not just for us, but for most of the world? And I really break it down into 4 buckets. And the first one is, this is truly what we'd say a novel pathogen, and none of us had pre-existing immunity. And that actually is a big, big factor. We'll talk about herd immunity later. Some of us are acquiring it through vaccine and some through infection. But without any pre-existing immunity, this was a big deal in terms of setting us up for a pandemic. The second thing, which I think people have noted and was a little bit slow to be understood, is transmission without symptoms. And there are other viruses or respiratory infections that can be transmitted without symptoms, but we generally think of influenza as only lasting maybe a day. You can transmit before you get those flu-like symptoms, you know, headache, sore throat, or just the myalgias. It is clear that with COVID-19, that pre-symptomatic or asymptomatic can actually be 2 to 3 days. And that makes us a lot harder to contain because we feel well, yet I still might be transmitting to my household or to my workers or to outside. The third thing I think, which also played into this, is that as we've gotten smarter, we realize that there are many, many presentations clinically to COVID-19. Initially, this was characterized as a respiratory infection, a pneumonia. That came out of China about a year ago, so we were all on guard for what we'd say respiratory presentations. But now, as we all know, there is a myriad of presentations. This was highlighted in the New York Times Magazine a couple of weeks ago. The anosmia, or loss of smell, is actually turns out to be a pretty specific sign and symptom, although not pathognomonic, but diarrhea. So there's GI symptoms. There's also headaches and other types of symptoms other than respiratory, which could make initially making the diagnosis a little bit more difficult. And finally is globalization. And we like to talk about SARS-1, which occurred going back to 2003 as what we'd say the first supersonic respiratory disease transmitted or primarily on people on airplanes. And we are a very connected world, as we all know now. And so again, if you look at travel patterns, not just in terms of our own mobility here in the homeland, but throughout the world, you can be incubating any disease across the continent and then bring it home 12 hours later. And this clearly occurred with obviously SARS-CoV-2, and we were a little bit late to catch up on that. We were all focused on what's going on in China. Oh, that's terrible, what's going on in Wuhan. In the meantime, it was already coming over across the pond, so to speak, and via Italy, as well as to China, into the east and west coast of the United States. Next slide, please. The other thing is our interventions. And I like this model. This is from Reason, who was an expert, a psychologist, just in terms of hazards and breaking down events in terms of prevention. In each quote unquote slice of the cheese is another barrier that may prevent an adverse outcome. And when you get all the holes in the cheese aligned, then you can get an adverse outcome. And how we've kind of looked at this, or I think an interesting way to look at it in terms of COVID-19 for the pandemic, is there are slices in the cheese that we would say are personal responsibilities. That is, do I wear my mask? Do I practice hygiene? Am I also doing good social distancing? Then there are some shared responsibilities that the government can layer on. And Dr. Wyllie mentioned some of those: bar closing, restrictions in terms of travel, in other kind of what we would say de-densifying things. And all these work to a certain degree, but again, a lot of them require human activity, and we're all human and it's hard to be perfect. And finally, this last slice of the cheese that we're in the middle of now is vaccine. And we do hope this is going to be the way forward in terms of not necessarily eliminating the virus, but getting us back to some sense of normality. Next slide, please. The other thing about vaccination is, as you know, it's fascinating. The vaccines were developed very quickly, but at the speed of science. There were no shortcuts taken. And then, of course, countries have been a little bit different in terms of the execution. Perhaps no surprise, Israel has been actually the most effective in getting shots into arm. There are some reasons for that. Everyone in Israel, as many of you may know, has to join an HMO. It's a smaller country, very high literacy rate, and actually you can see that that they have delivered the highest rate to date in their population. I think it's now maybe 40 to 50% in terms of Israelis have received at least one of the vaccines in the arm. As Dr. Wyllie mentioned, we have the most vaccine in the world. We control now about a third of the supply. And our initiation was perhaps a little bit bumpy, but we're getting better. And as Dr. Wyllie mentioned, we're about 1.7 million vaccines in the Americans' army each day. And obviously the goal is to continue to increase that as much as possible, where we're limited primarily by supply now. Next slide. I want to talk a little bit about herd immunity, because I think there is a little confusion about that. Perhaps one of the best metaphors I heard was, being an old Boy Scout, is campfire. And so when you're trying to build a campfire, on the left, if you've got the dry logs, you can start, and you can really start the fire, and the fire will continue with more dry logs. And you can think about dry logs as being people without immunity in the population, which we started with. As opposed to that, it's much more difficult to start the fire with wet logs. And so wet logs in a population would be people who have immunity, hopefully by vaccination, but also by natural infection. And of course, if you get to a population where your immunity, as Dr. Wyllie mentioned, gets up to 75 to 80 to 90%, that makes it very hard for the virus to, even if it's present, to continue to transmit. And in medical terms, we talk about R naught, that is how many average infections does a single person transmit. Once that number goes below 1, you're in negative territory and you begin to get a control on the pandemic. And that is where we are hoping to go, as we mentioned, with all the non-pharmacologic interventions, but also with vaccination. Next slide, please. Some of the questions that even our own people, am I still wearing a mask despite the fact I'm one of the 4%ers, fortunately, that have gotten 2 vaccines in over 2 weeks? And the answer to that is yes. A lot of that is we still don't have data on transmission after vaccination. So it's still possible that I may be able to get infected, not show any disease, but still could spread either to my own household or to the patients. And the second aspect of that, of course, is we still want to model this behavior in the hospital. And we still have people, our own employees, that cannot or are not taking the vaccine yet. So we don't know who is and who is not what we would say protected. And so we've taken a very conservative approach. Having said that, I think many of you may have noted CDC is now adjusting some of the recommendations, say for quarantine, based upon vaccination status. So last week, for instance, if you have been vaccinated and then exposed to somebody with known COVID, you no longer need to quarantine. And that's, I think, a big positive as we move forward in trying to also get our lives back with exposures or non-exposures. Next slide, please. And again, many of you might have heard Dr. Fauci a couple of weeks ago talk about the need for double masking and maybe seeing the CDC report come out about double masking. The CDC guidelines, I would say my interpretation is the mask should fit well. And so we wear a variety of masks here, including the surgical mask, which can fit tightly. All of us don't need to wear the N95s, but that I think is the most important thing, is a tightly fitted mask. And if the mask you're using also should be double layered for the homemade mask. So that is how I interpret that, is that if you have a good tight fitting mask that's a double layer, you don't need a quote unquote double mask. And I think I have another slide next. I guess what it's not going to fix is what we see the people wearing the mask below the nose or on the head or things of this nature. So again, it's about proper execution. I do want to pivot a little because I think this has been in the news in terms of what we call the variants of concern. And I know I'm not going to give a genetics lesson, but basically we're talking about an RNA virus here. An RNA virus often make mistakes or often have errors in terms of its coding. And so we see a lot of what we would say mutations in RNA viruses. Now, actually, coronaviruses actually have what we say a polymerase, which can help check some of those errors. So it's not as I would say, the fidelity of replication is much better than other RNA viruses such as HIV. So a mutation is just a change in that genetic sequence, that code. A variant are any genomes that may differ in a sequence. And when we really talk about strains or variants, we really should be talking about that there's something special about these mutations in this particular virus that make it either more transmissible, less transmissible, more may susceptible to vaccine or less. And so that's what you're hearing about these strains. Now to date, most of us have heard about the B117 strain, quote unquote, the United Kingdom. I must admit that the WHO does not like tagging geography to the strains because of stigma, but it kind of sticks that way. There's a B135 strain in South Africa, which you've heard of, which also has mutations in the spike and actually has proven to be less efficacious to some of the vaccines that are out there, in particular the AstraZeneca. There's Brazil strain. There's a California strain, and maybe some of you have even heard about, there's probably now a New York variant that's been described that was reported yesterday. So from a pragmatic point of view, it's not going to change the way forward. We are still going to be pushing vaccine into arms and still doing non-pharmacologic interventions. What the CDC now has done is provided more money and more resources so that the United States can do more sequencing of all the viruses to get a better idea about spread. Next slide. I want to also pivot now to what we call recovery, and not just recovery from the pandemic, but also from the patient point of view. I'm happy to announce that the Cleveland Clinic's what we call Recovery Clinic opened this week under the leadership of many of our clinicians, including one of my good colleagues, Dr. Kristen England here in ID. But this is a need. And I think the way that we view this, we know that, for instance, after COVID infection, even if you're young and healthy, about 30% of people will still have a lingering symptom at 3 weeks. And based upon one of the largest follow-up studies that was published from China this week, we know that people hospitalized with COVID can have many lingering symptoms, up to 30 to 40%, including physical and non-physical type ailments. So the goal of our Recover Clinic, which you're seeing here and across the nation now, is to better understand recovery in COVID-19, to also not just obviously listen to the patients and get the patients into services post-COVID that still may be lingering for further investigation. I talked about the anosmia, that's an easy one, but sometimes the smell won't come back, or sometimes the smell will come back in an odd way. And so our ENT people are involved in that. Many of you have also heard about other issues that may affect the heart, that may affect lingering in the lungs. And so we're standing up all of our clinical services we have at the clinic to support the Recover Clinic. Next slide, please. Let's see. That's a complicated slide. Okay. I think that's my last slide, so thank you.
So we have a number of questions that have come in on the chat, and then we had lots of questions that came in prior to today's seminar. So I just want to start with Dr. Wyllie. A number of members in the audience today are very curious about when they're going to be contacted for the vaccine. Several of them are meet the criteria of 65 or over. They're Cleveland Clinic patients, and they have not been contacted in my chart. If you could explain why the vaccine is so limited right now, I think people would be very happy to understand that.
Sure, Andrea, and it's been a very frustrating experience for most people. And that's because the number of people who were deemed eligible, like I said, over the age of 65 and 5-year increments over the last several weeks is far outstrips the amount of vaccine which is available in the state of Ohio. So at any given week, we have of 200 to 250,000 vaccines. In the last 6 or 7 weeks, the Ohio Department of Health and the governor have taken about 50 to 55,000 of those vaccines, and they've sequestered them for people who work in schools, K through 12, not only teachers, but the janitorial staff and the cafeteria workers in those schools so that they can get kids back to school. So that took about 50,000 doses out of that 200 to 250, and only left us about 200 left. Those 200 left got distributed to every hospital and every local health department in Ohio. The hospitals got about half of it, the local health departments got the other half, and CVS and Walgreens are in the mix, and they got a good chunk of it as well. The reason for the CVS and Walgreens is because they wanted to make the distribution of points fairly wide. So even though you're a Cleveland Clinic patient, we're getting about 3,000 to 3,500 doses a week. If we look at our number of patients over 65 years of age, it's 450,000. And we've only gotten about 50,000 doses to give to those 450,000. If we add in all those people with medical condition, it's another 20 to 25,000. And again, we only got about 50,000 doses for nearly 500,000. So that's why there's this frustration in terms of getting the vaccine. The government, federal government, is also doing some things to try to increase the vaccine distribution. So last week, they sent 1 million doses around the United States, about 30,000 to Ohio, 35,000, which went, in our case, to Rite Aid and to Kroger's. And so they got vaccine, and that was from the federal government, not going through the state, but distributing it on its own. So we have these different distribution platforms, these different sites, and that's why it's been a little bit frustrated. Moving into the future, there's not going to be really anybody added for a few weeks while the governor lets the vaccine manufactured and being distributed to the health systems and the local pharmacies and the local boards of health start to catch up with all those eligible people, because we have 1.3 million have been vaccinated. We've got at least twice that much, 2.6 or 2.7 million people who have been deemed eligible. So we've got a ways to go to catch up with everybody's that announcement that, gee, you're eligible, but sorry, we don't have vaccine. So we'll be catching up in the next several weeks. The supply chain to the government has increased. So it started at about 8.5, 8.7 million. A couple of weeks ago, it went up to 10 million. The Biden administration has announced that within the next week or two, it's going to go up to 13.5 million. But still, it's going to take us a long time to meet the demand out there, even for those who've been announced, 65 years of age and older, and those with those chronic medical conditions, which I listed. So I think we're asking everybody to be patient, to please be safe. As Dr. Gordon said, wear a mask, socially distance. You're going to even have to do that after you get the vaccine, but it's going to take us a while for vaccine production to catch up. The Biden administration has announced, with the extra 200 million, 100 million coming from Pfizer, 100 million coming from Moderna, that will give 300 million of each, total of 600 million. That's virtually every adult in the United States. By the end of July, there should be enough vaccine to start vaccinating everyone who wants it.
So is there a problem with the vaccine system if people register in multiple places for the vaccine?
It makes it a little cumbersome because we have to call and say, did you get it? So we're keeping a list for people and we're about a third of the patients say, gee, I got it elsewhere. They went to the Rite Aid, they went to the Kroger, they went to the CVS, the Walgreens, and they got it elsewhere. That's great. But we use all the vaccine that we get every week. There's no holdover from week to week. We get it on Thursday, it's gone by the following Thursday or Friday. We're completely out.
So I'm going to switch over to Dr. Gordon about questions we've been getting about side effects and adverse reactions. Can you talk about that for what's going on with side effects?
Yeah, so in particular, just speaking about the mRNA vaccines, which are the only ones right currently approved, that the safety profile for these vaccines has been very, 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 very good. So this includes not only what we would call the information that was submitted to the FDA, but also the post EUA kind of experience, which includes for both now millions of doses. The one side effect I think that people there was a little signal there is this issue that some people have been reported to have anaphylaxis. This has occurred at a rate of about maybe 1 in a million or that regards. And these are primarily in people that already have a history of anaphylaxis to some sort of medication. So most of these people are already having EpiPens. And as you note, or as you hear, everyone that gets these vaccines is going to be observed for 15 minutes afterwards, regardless. Those with a history of reactions to medications will be watched for at least 30 minutes. The only absolute contraindication to not getting this vaccine, other than one doesn't want it, is whether you've had an anaphylactic or a severe reaction to the Moderna or the Pfizer. And that's, again, relatively rare in small numbers. So I do want to emphasize that it's very safe. I also want to emphasize that your arm's going to hurt, and that's a good thing. So what we call that is reactogenicity. So for those of you that have gotten your Shingrix vaccines or your tetanus or Tdap, you're going to get, many people are going to, up to 30 to 40% of people will experience that soreness in the arm, sometimes an associated a little bit of lymph node that in some, that is generally treated with either Tylenol or Motrin after the vaccine and resolves itself in 24 to 48 hours. But that's something that is no different than any other vaccines when you compare it to in terms of reporting. The other thing patients will get is there is a app that, that you can download and that you'll get queried about your, any side effects. All that data is being collected. And again, now we're almost 3 months into this. No safety signal has been reported after the release globally in terms of the mRNA products.
Is there anybody who shouldn't get the vaccine?
So anyone who should get the vaccine. So I think the issue is obviously there's an age component there, right? These are still an adult vaccines. Pfizer, you can go to 16, but everyone else is going to be over 18. I would say, Andy, I mean, from my point of view, the answer to that is unless you've got that severe reaction, again, to the first dose, the answer to that, I would say, is that there is no contraindications. Now, people will ask, look at Dr. Grodin, I have this immunosuppressed, I'm a transplant, I'm on this and that. Am I going to respond to the vaccine? It is true we do not have the data yet on certain subpopulations. So there's a difference, I think, between will you definitely respond to it or is it safe? I can say that it is a very safe vaccine. That's not to say that everybody is going to respond, especially when we talk about certain subpopulations, and that's being studied now as well.
How do you respond to people who question the safety of the vaccine, given that it was developed so much more quickly than most?
Yeah, so I do want to, I think it's great. I do want to, I say that vaccine hesitancy is different than, people should always ask about what's going into their arm. So we welcome that dialogue. What I would say is that you have to understand, as opposed to prior vaccine development, one is this was a global effort, multinationals, billions of dollars, lots of companies in terms of this. The other thing is, if you look at the mRNA platform, this platform was built on prior research for mRNA, say for Zika. And so it wasn't developed overnight. The techniques and a lot of this basic science has been developed over time. And as I said, one of the reasons why we're able to get vaccines so quickly is not just because of good old ingenuity, both in the homeland and globally, and not because it was well funded, but it went at the speed of science. There were no shortcuts in terms of bringing it to into humans in terms of safety or efficacy. It was done by the books.
So here's a $64 million question. What does life look like after the vaccine? Can we hug our grandchildren? Can we travel? Can we leave the house?
Well, I'll defer to Dr. Wyllie, but I tend to be a half full cup guy. So I think how this is going to play out, Andy, we're already beginning to see in terms of, as Dr. Wyllie mentioned, we're in a downslope now in terms of cases, not just here in the homeland, but globally. I wouldn't say that's all because of obviously vaccine or because we're all wearing our mask. Some of this might have to do with the seasonality of the COVID virus itself. It's unlikely it's going to disappear. However, as we continue to get immunity here in our population, either as again, by vaccination or by exposure. And remember, estimates are, despite the fact, I think it was mentioned earlier by Dr. Wyllie, 27 million US cases, most people would multiply that by 4 in terms of people that were inapparent or had milder infections. So there is a significant amount of what we would say herd immunity naturally going out. But what we believe is that the second time around, vaccine or not vaccine, even with the variants, is that the likelihood of more severe disease is going to be less in everybody. And so that's a good thing. And so remember, there were other coronaviruses that circulate, and one in particular was thought to be resulting of a big pandemic in 1890s. And that is now more of a cold-like symptom for most people. I do think with vaccination that is the most likely outcome as we look forward to the, to the year coming. You will be seeing quote unquote passports for immunity in terms of this. We're already beginning to see proof of immunization may allow you to do certain things. I do want to emphasize also for the group, we do not have a blood test yet that's a correlate of protection for either people that got COVID or vaccine. They're working on that. It's very close. But all these antibody tests that are out there now are not validated tests for individual immunity. So that is not going to be, that's not the answer yet.
Dr. Wyllie, can you explain the vaccination process in a little more detail?
Sure, I think it was easier than the last question that Dr. Grodin got. So the vaccination process is there's a short pre-registration that you do, and that talks about kind of just a little bit about your background, but not much. It's only 4 or 5 straightforward questions about any medical illness and the fact that you're going to come back for a second vaccination. Usually when you get the first vaccine or schedule it, the second dose is usually automatically scheduled at that time. So you go in, you make sure that you can roll up your sleeve, and it's way up to the top of the arm. So make sure that you don't have to disrobe, but wear something which you can lift up, over over your shoulder. And then it's a very, very thin needle. They inject it quickly. It's a very small volume, about 1.7 to 1.3 ml. So very, very tiny volume. It just squirts in, second or less. And then, but you have to sit then for 15 minutes. And the reason is because what Dr. Grodin mentioned, if you're going to have an allergic reaction or an anaphylactic reaction, almost all of them occur within 15 minutes. So we ask you to sit on a chair, socially distanced 6 feet from everybody else. We give you a timer, the timer goes off and you're free to go after that. So it's quick, it's efficient, it's in and out, and most people are pleased with the experience in general. There's scheduled appointments, so we don't want people stacking up outside, waiting to get in and not socially distanced. And we don't want people to wait out in the cold, particularly in this winter weather. So we give you an appointment time. We have a whole series of vaccinators in every site, and we can handle anywhere from 6 to 12 people at once.
What if somebody gets COVID in between the first vaccine and the second vaccine? How does that get handled?
Yeah, Dr. Grodin can chime in on this as well, but the CDC right now is encouraging, just because you get COVID doesn't mean that you can't give the second dose. Obviously, if you're ill, that's going to be postponed. If you have COVID with a lot of symptoms, there is a suggestion that if you have COVID, that you wait 90 days so that the antibodies that your body makes to the COVID won't interrupt the effectiveness of the vaccine. But other people are saying that maybe is a little bit of over concern, but I'll flip that back to Dr. Grodin as well.
Yeah, so we've all got a lot of experience. If you remember, we started vaccinating; it was still very high levels, and so we have had patients or healthcare providers develop COVID before they've completed the series. I want to point out is that the data is very good. Is that you're going to get some immunity kicking in after the first 12 days of the first shot in terms of this nature. So it's not full immunity, but you will get some immunity. The cases that I've seen too in people who have got them between the first and the second, very paucisymptomatic. So, a lot of just rhinitis or small type of symptoms. And generally, as Dr. Wyllie said, what we'll mention is once you're recovered, which is generally 10 days after the positive COVID test, and no fevers for 24 hours, you can get back in the queue to get that second vaccine. The other thing I think is to point out is that, initially when these were released, there was a 21-day for the Pfizer and a 28-day for the second vaccine, for the interval for the second vaccination. CDC and everyone has kind of pulled back a little bit more leniency in giving up to 6 weeks, understanding that there's different time pressures. Remember, the trials were done to get protection as soon as possible in the pandemic, and you will not compromise your ability to develop full immunity if you are delayed for some reason in terms of after that 21 or 28 for Pfizer. So I think that that's also an important thing. And the final thing on the vaccine is that I know the pediatricians know this well, but adults too, anytime you got to have more than one vaccine, there's going to be fall off, things happen. And so that's why we're all looking forward potentially to the J&J vaccine if it gets approval, because that's a one and done. And that might open up, getting vaccine to different types of populations. It may be harder to come back for the second vaccine.
How effective are the vaccines against the variants? You mentioned that briefly in your presentation. Is there more studies going on now that we're going to learn more about that soon?
Yeah, so that becomes complicated, but I think if you look at what we call vaccine efficacy, that all the primary endpoints that is efficacy against preventing infection, meaning positive RT-PCR. That is important. That's that 95% you see in the Pfizer and Moderna. But there's other measures of, we would say, effectiveness. And that's, for instance, Andy, I might get COVID-19 after the vaccine, but I might get a more mild disease to prevent me from getting hospitalized or death. And that, most of us would think, is really, that's the big win here for vaccines. So you might have seen yesterday, you might have heard South Africa suspended use of the AstraZeneca because the efficacy against that variant of concern was about 57% in some initial trials. But the WHO is still pushed forward and believes that it still didn't show that it didn't protect against severe disease, which would be important. And again, still recommends that the vaccine that's available, AstraZeneca around the world or other products, including our mRNA, is the one that you should use as the one that's available, because again, the other endpoints that are important are going to be prevention of severe disease, hospitalization, and death. And obviously that data is rolling out. And there is a concern, obviously, that efficacy may fall with some of the variants. And already the vaccine companies are gearing up for boosters or modifying, to be more effective against some of the variants that we're seeing.
Do you think there's going to be a vaccine for children? I could ask that of Dr. Wyllie, or a pediatrician.
Yeah, there are studies being done now they've dropped the age down to 12. In that, we'll probably have information about that in June or July. And I would anticipate kids being vaccinated probably before the start of school. And the last group will be those under 12. And obviously you start with you want to take the least risk with the youngest patients. And so you're starting with healthy adults between the age of 16 or 18 and 64 or 65. And then you look at it in older people as well. And then you start down into the pediatric age group. But yes, I assume it'll be available. There's no reason to think that it won't work, but that point still needs to be proven.
So what do you predict the next few months are going to look like in terms of this pandemic?
I think the next few months are going to look a lot like the past 11 months, 12 months. I think we're going to still have to wear masks. We're going to have to socially distance. I think more people, as they get the vaccine, will be relaxed. But as Dr. Grodin said, that doesn't mean that you can get away from wearing your mask, because the vaccine, even the Moderna and the Pfizer, are 95% effective, not 100% effective. So you still may get symptoms, or you still may pass it on to somebody else, which is another reason to wear a mask. So two reasons. Mask is to prevent you from giving it to somebody else, and to prevent you from getting it. So I don't think that's going to change for a while. The president said yesterday in the news conference on CNN that he expects things to return to normal around the holiday time in December. Let's keep our fingers crossed and hope that that's the case. But I think we've got a ways to go in terms of more vaccine being available, and then actually getting it into arms, not only the first vaccine, but as Dr. Grodin said, for the best chance of prevention, getting that second vaccine in until we get the Johnson & Johnson, which is just a one-dose shot, and that'll help out a lot.
So we're hearing about many patients who are delaying their care or their screenings. Is it safe to get routine care in our hospitals?
It is safe, and it's extraordinarily important. Andrea, we know from looking at our own patients as well as population studies that people are not coming into the emergency departments for things, even heart attacks and strokes, and they're coming in late. And unfortunately, late, things become fixed, and we can't put a cardiac stent in because the clot is fibrotic at that point. We can't revascularize the heart. We can't revascularize the brain. So people need to come in. They need to get routine care. They certainly need to get emergency care if they don't know what's going on. The cases which occur in the hospital are very, very small. Almost all the cases that we've seen occur in the community, including in our caregivers. So they require it in the community, and everybody's much more cautious in the hospital. So hospitals are safe, clinics are safe, and we're really urging people not to delay their care.
It's a real testament to the PPE and the masking that we are following so strictly in the hospital.
Yes, an example of that is what happened to flu. Everybody put on the mask and washed hands, and we had no flu this season. Essentially, the flu season evaporated in the United States, but also in Australia and the Southern Hemisphere, which had COVID first. So we know how to cure the flu.
Okay. Well, I want to thank you both so much. Really great perspective tonight, insight. I want to thank everyone who's attended today's webinar. We really appreciate that you've shared an hour with us, and we hope that you found this time to be meaningful. So on the screen, we're going to show you some additional contact information for the Cleveland Clinic. And this information is also going to be distributed through a Federation email, which is going to be sent to you following today's session. Please stay connected and stay informed. A recording of this webinar will be accessible on the Federation's website. And please reach out to the Federation if you'd like a transcript of this webinar. I invite you to join the Federation for upcoming events, including the weekly wellness series, which offers a variety of virtual activities for all ages that support our mind, body, spirit, and community. Thank you, everyone. Stay safe, stay healthy, and thank you very much, Dr. Grodin and Dr. Wyllie, for your wisdom today.